approach to fever in ICU patients. Welcome to this learning session on the approach used for fever in ICU patients. Fever in ICU patients is quite common and may be associated with morbidity and mortality. In the ICU, fever should prompt important diagnostic and treatment decisions. ICU patients frequently have multiple infectious and non-infectious causes of fever, necessitating a systematic and comprehensive diagnostic approach. By the end of this topic, you should be able to define fever, identify the various etiological factors of fever in an ICU patient, and discuss the diagnostic approaches and management of fever. The incidence of fever is common amongst ICU patients. Fever is the body's host defense mechanism. Although it is commonly associated with infections, the relationship between infection and elevation of body's temperature is poorly understood. The main dilemma in this situation is to exclude non-infectious causes of fever, and then to determine the site and likely pathogens of the identified infections. ICU patients frequently have multiple etiologic factors that cause fever, necessitating a systematic diagnostic approach. Moving on, we will define fever and explore different methods to measure a patient's body temperature. A normal body temperature is considered to be 37 degrees Celsius or 98.6 degrees Fahrenheit, with a circadian variation of between 0.5 to 1 degree Celsius. The Society of Critical Care Medicine's practice parameters defines fever in patients in the ICU at a temperature of 38.3 degrees Celsius or 101 degrees Fahrenheit. If the patient has other features of an infection, a temperature of 38.3 degrees Celsius warrants further investigation. Numerous methods exist to measure body temperature. Some of them include: the venous blood in the pulmonary artery is considered as the optimal site for core temperature measurement. However, it requires placement of a pulmonary artery catheter. Rectal temperatures are a few tenths of a degree higher than the core temperature. Oral measurement of the temperature gets influenced by events like eating, drinking, or the presence of respiratory devices, which deliver warm gas. Auxiliary measurements lack reproducibility. Body temperature is accurately measured by an intravascular thermistor. Measuring temperature by infrared ear thermometry, or with an electric probe in the rectum, is an acceptable alternative. In the next slide, we will tackle the epidemiology of fever. The epidemiology of fever is as follows. Fever complicates up to 70% of all ICU admissions and is often due to an infection or another serious condition. However, its rates of occurrence range from 26 to 88% and vary depending on the ICU patient population. A fever is also associated with an increased length of stay and cost of care. When compared to patients without fever, it can result in poor outcomes, especially amongst patients with traumatic head injury, subarachnoid hemorrhage, or pancreatitis. A fever can prompt unnecessary investigations and can lead to inappropriate antimicrobial use. The importance of a fever as a pathophysiological process is poorly understood. While on one hand, fever may be an appropriate adaptation to an underlying infective process, in other situations, it can be harmful. For example, patients with high peak temperatures between 39 and 39.4 degrees Celsius have significantly lower hospital mortality as compared to those with peak temperatures between 36.5 and 36.9 degrees Celsius. In contrast, mortality increases with rising temperature in patients with non-infectious cases of fever. The following slide will demonstrate the classifications of fever. The fever patterns can be classified as continuous, remittent, intermittent, relapsing. Most patients have remittent or intermittent fever due to infection, which usually follows a diurnal variation. The appearance of fever at different points in time during the course of a patient's illness can provide some diagnostic clues. The cases of fever after 48 hours of institution of mechanical ventilation are secondary to a developing pneumonia. The cases of fever which develop 5 to 7 days postoperatively are related to abscess formation. The cases of fever, which arise 10 to 14 days post-antibiotics for intra-abdominal abscess, can be due to fungal infections. Next, we will explore some non-infectious causes of fever in ICU patients. The non-infectious sources of fever in an ICU patient include inflammatory conditions like reaction to medications or blood products, collagen vascular diseases, systemic lupus erythematous, rheumatoid arthritis, vasculitis, hypersensitivity vasculitis, Henna-Oakeshott line purpura, Wegener's granulomatosis, giant cell arteritis, microcrystalline arthritis, gout, pseudogout, post-pericardiotomy syndrome, pancreatitis, and local reaction to intramuscular injections. Vascular conditions like deep venous thrombophlebitis, pulmonary embolism, dissecting aortic aneurysm, mesenteric ischemia or infarction, myocardial infarction, hemorrhage into the central nervous system or CNS, retroperitoneum, joints, lungs, and adrenals. Metabolic conditions like heat stroke, hyperthyroidism, adrenal insufficiency or hemorrhage, alcohol withdrawal, seizures, neuroleptic malignant syndrome, and malignant hyperthermia secondary to anesthesia or medications. Neoplasia, which includes lymphoma, renal cell carcinoma, hepatocellular carcinoma, malignancy metastatic to liver, and colon carcinoma. Moving on, we will list some infectious sources of fever in an ICU patient. The infectious sources of fever in an ICU patient include urinary tract infections, can lead to pyelonephritis, prostatitis, or prostatic abscess. Infections due to vascular devices at the intravenous access site and the cellulitis intraatrial access site. Respiratory infections like tracheobronchitis, pneumonia, sinusitis, epedema, and lung abscess. Surgery-related wound infections and deep-seated abscess. Skin or soft tissue infections can lead to decubitus ulcer with cellulitis or fasciitis, or myositis and cellulitis. Gastrointestinal infections can cause antibiotic-associated colitis or Clostridium difficile colitis, ischemic colitis, biliary infection, transfusion-related hepatitis, intra-abdominal abscess, and diverticulitis. Prosthetic devices such as cardiac valve or pacemaker, joint replacement prosthesis, peritoneal dialysis catheter, and CNS intraventricular shunt can cause disastrous infections such as peritonitis. Miscellaneous causes for infection may include pyarthrosis, osteomyelitis, and meningitis. The next slide covers the pathophysiology of fever.